Please, can you hear me? If you can hear me, you can just go to the chat and type yes. If you still cannot hear me, please check the volume on your device. Make sure the volume is up. If it is the network, kindly check. Maybe you should change your position to see if you would get a better feedback. Great. I can see quite a number of us responding here, so I do believe you can all hear me. All right. So I hope you had a great week, and we are back again. We thank God for bringing us together again for another meet. Last week when we met, we had a bit of discussions on what pharmacology is, what the course is also going to be about. And then also we took a look at the differences between medicines and drugs. We looked at the drug development process. And then we looked at prescription, non-prescription drugs, and then also a few definitions. I hope that we all learned something last week. Please, is there anyone who needs a clarification, or is there anyone with a question from last week? If you happen to have a question, when we're ending the class, there were a few hands. I asked that they put it on the platform, but nobody put anything on the platform. And so, if you happen to have any questions, please. All right, Chris. Chris, please you can unmute and speak. Hello, Chris, can you hear me? You can unmute. Click on the microphone icon, and that will unmute you, and then you can speak. All right. Whilst Chris does that, let me ask Joshua. Okay, Joshua, please, you can unmute.
Mom, my issue is I think last week some of us were not able to make the class, but apparently I listened to the slide. I saw you created groups for groups which we don't have. So I'm just asking how probably we could diffuse it into those groups that we have.
Please, your line was breaking. I don't know if it's from my end. I got the part that you said you were not in class.
Yes,
Yes.
ma'am. But
Uh-huh.
I
And
and apparently groups were created. I listened
oh,
to the whole. I listened to the. I later came and listened to the whole class and then made notes. But I saw you created groups for people to join, and unfortunately, some of us don't have those groups. So
okay.
I'm just.
Okay.
Yeah.
All right. Please, the groups that were created was for a short discussion. So it is not groups for any assignment. I had to sort one of my colleagues out. I had to have a discussion with the HOD whilst I had started lecture. So I gave them something to discuss whilst I sort that issue out. So these were not permanent groups. Neither were they for any assignment. It was just for a short discussion on the differences between the similarities and differences between drugs and medicines. Thank you. I hope, Joshua, you are okay. So if there are any, I'm thinking of if I'm thinking of any, I will let the reps create a group. I don't like using the Zoom to create groups simply because some of us, we still don't know how to use the Zoom to even accept to join a room. So for me, as much as possible, and as much as I want to reduce stress level on my side and on your side, okay, if I want groups, it's the reps who create the group so that everybody is part of the group. Yeah. All right. So I shared with you those of some people said they just joined the class. No problem if you join, please get in touch with your course rep and we will let you join the Telegram page where you will find the documents that I've already shared with the class. Okay. Um, I've also posted the two meetings that we've had, the recording. It's also there. You just need to make some time and then go through the two recordings. I've also shared with you the course outline, and then some lecture notes as well, and other reading materials. Please forgive me if my voice seemed a bit down. Um, I had an extraction of one of my tooth a couple of days back, so um, I'm not able to talk very well. All right, good. So we got to know this last during the week when I posted the slides on the Telegram page. I said we are going to be discussing pharmacokinetics, and we are going to look at the first two processes in pharmacokinetics. We got to know that pharmacokinetics is what our bodies does the drugs. I don't know if you have ever wondered what happens if I take my medication, if I swallow it, what happens if it is injected into my muscle? What happens to it? I don't know if any of you had any thoughts on that. What happens to the drug? Does the drug stay in my body forever and ever? How does the drug come out? How long is it staying in my body? All right, I don't know. It's some of these questions that actually uh, made me want to go and study pharmacology. All right, to understand more about drugs. At our first meeting, just by the way, at our first meeting, one of the things that we talked about is the fact that you would have to use your names, okay, so that it's easy to call you. Some of us still have, I can see somebody, Zoom user. I don't know who this Zoom user is, okay? So please, if you are the person, click on the small dots that are there. You see rename, all right? If you are not using your name or if your name does not appear, all right, click on the small dots, you see rename, and then you put in your name instead of Zoom user. All right. So we said that today we will discuss the first two processes. The first two processes. We will discuss drug absorption and drug distribution. I hope you are able to do that today. So I'm going to ask a couple of questions. Now, I asked all of us to take a look at the lectures. Okay. I asked all of us to do that, to look at the slides, go through the slides. and then we will have a discussion. All right. So I will start by asking a couple of questions, and I hope that we would all be able to answer the questions, and then we'll use that as a platform for our discussion. So the first question I want to is, what is pharmacokinetics? If you have an answer, you can raise your hand or just go to the chat and type your answer. What is pharmacokinetics? Yes, endurance. Please, you can unmute. Hello, endurance. Please unmute.
Yeah, hello, good afternoon, madam.
Good afternoon.
Yeah, please, pharmacokinetics is what happens to the drug in the body when it when we when we take in the drug. We got to know that when it's absorbed, then distributed through the body cells and tissues, and it moves to metabolism before it's eliminated from the body. So basically, it is what happens in the body when we take in the drug. Thank you.
Thank you very much. Endurance. We'll ask Kwame to also add something. Kwame to four. Please, you can unmute. Is there anything you would want to add?
All right, madam. So just as our sister said, kinetic means movement. So with pharmacokinetic, we are dealing with what happens to the drugs whilst it is moving throughout our body.
All right.
So it's involved in four processes, as our sister mentioned. So when you take the drug, whilst it is moving through your body, it is being absorbed, then it is distributed by the blood to various sites. Then it is sent to the liver for metabolism. And finally, the drug comes out of the body by excretion, usually by the kidneys and other excretory organs.
Thank you very much, Mr. Tufo. All right. I believe that we have all, based on the comments I'm getting and what our two speakers have just shared with us, we know what pharmacokinetics is. I don't think we'll add more. Okay. So we've gotten to know what pharmacokinetics is, the movements of the drug throughout the body from the point of absorption where the drug is absorbed into the body, when the drug is introduced, through distribution as the drug is transported through the circulating fluids to the various tissues and cells and organs, and then how the drug is made ready, as in how the drug is metabolized so that the body can then get rid of it. So there are four main processes as we've gotten to know. My next question is, why should we as nurses be concerned about pharmacokinetics? Because I just have to administer the drug. So if I have to just administer the drug, why should I be concerned? I'm doing my job, but why should I be concerned? Or why should I learn about this? Yes, Ebenezer, please, you can unmute. Hello, Ebenezer.
Hello.
Yes.
Yes. Why, as nurses, we should be concerned to know pharmacokinetics or how the drug is being absorbed, is being distributed, metabolized, and excreted is because we need to know at what point in time or at what stage of the drug is after being administered so that we can be able to track the drug and know maybe the route to administer the drug. This absorbed by so if we get to know the absorption process of the drug, we will know of which we should administer the drug. If you get to know how the drug is, then we will know the effect of the effect that drug is to impose on our bodies, so that we can be able to track the drug and check its complications. Thank you. Or its side effects.
All right. Thank you very much. Let's hear Catherine. Catherine.
Madam, please, as a nurse, it's very important for us to study pharmacokinetics so that we will know the route of administration. And also, in case we are giving any drug, we will be able to detect the therapeutic and the therapeutic effect and also the adverse effect. So, for instance, if you have administered a drug and there is a reaction, we also know a way of counteracting it or neutralizing it so that it doesn't cause harm to our patients.
All right. Thank you very much, Catherine. Kwame, you spoke, so let me let somebody else speak. So Joshua, Kwame, it's not intentional. We just want to hear other people. Everybody cannot talk. So,
Mom, I think
mhm.
I think an in-depth knowledge on pharmacokinetics will let us understand how much of a drug we have available in our blood. That's the bioavailability of the drug. That is, if it is administered. It also makes us see deviations or adverse drug reactions when they happen in a human being, and which particular what we could do to better solve those drugs.
All right. All right. Thank you very much. Gifty, please, you can unmute.
Please, it provides knowledge on how drug absorption, distribution, metabolism, and elimination will help minimize adverse effects through drug dosage and administration methods.
All right. Thank you very much, Sister Gifty. Let me ask. Esau raised his hand the last time. Esau, please, let's hear you last.
Okay, madam, thank you very much. Just to add to what some of my colleagues said, it also helps to avoid medication errors and also broaden our knowledge scope on pharmacology as well.
All right. I know we all want to speak. Otherwise, if I say I want everybody to talk, we will not finish. Okay, so we'll be having the discussion. So as and when the opportunity comes, we would all get the opportunity to speak. Okay. So let me just summarize. So one thing I want us to get clearly is the fact that we are looking at the drug, the movement of it in the body. Okay. When you talk about drug effects, be it therapeutic effects, adverse effects, side effects, when you talk about drug effects, we are talking about pharmacodynamics. Drug effects, pharmacodynamics. Drug action, pharmacodynamics. Mechanism of action of the drug, pharmacodynamics. I want us to get this very clear. Both of these principles work hand in hand, yes. But when we talk about effects, we are looking at pharmacodynamics. Now, as a nurse, like some of you rightly said, we need to study pharmacokinetics. If you don't know the roots and how drugs are absorbed through these routes, when it will be difficult for you to choose the patient and which kind of route you should administer the drug. Yes, we are not prescribers, but one of the things that we do as nurses is that we are patient advocates. So if I know that this drug is an oral drug, my patients cannot swallow. And for that matter, if I try and administer the drug, it may not be properly absorbed because maybe the oral route may be impaired. The drug may even be what do you call it? Maybe a drug that I cannot crush or dissolve in fluid so that I can administer through, say, NG tube that has been passed for my patient. If that is the case, you need to advocate that so that your patient gets a different dosage form so that the drug can be well absorbed. So we need to study pharmacokinetics for several reasons. Some of them you have already said. One of the main reasons is that to rightly educate your patient. Now, let me tell you a story that I usually tell my students. When I started working, we had this youth employment. The ones we were calling Kufo or Atamils nurses. Okay. And one of the ladies who came to work where I was working in the particular ward had admission to go and do something else. So she stopped, went, came back a couple of months later that, oh, the symptom she described was basically candidiasis. So we just told her, oh, go to the pharmacy, not the hospital pharmacy, any pharmacy at all. So she went to a pharmacy shop. They gave her pastries, Nystatin pastries. And this lady, I don't know whether the pharmacist did not educate her well, or she did not hear or listen to what was said to her. She got home and swallowed all of them instead of inserting them, the drugs into her vagina. Now, if I am the nurse and I have a patient like this, and I don't know that this drug, this is the root, all right? If I don't know, how would I educate my patient? I will not be able to educate my patient. And most of us, we even, the way we even educate the patient makes our patients not adhere to the treatments that we give. This is simply because we don't educate them well. You know that the drug is taken every 8 hours, but I just tell the woman, take it 3 times a day. Now, I'm happy one of you said, so that we know the half-life. In the chats, one of you said it. Okay. One of you said that, oh, that will help us to know the half-life. Now, if we are talking, we'll talk about half-life in metabolism and excretion. If we are talking about that, right, and you know the half-life of the drug, you can easily educate the patient and tell the patient, oh, you are supposed to take this drug at this time, 6 a.m., 2 p.m., 10 p.m. If you miss the times, these are the possible effects. If you don't take it, you would see the therapeutic effect. If you don't take it at the 2 p.m., the 10 p.m. and continue, the concentration of the drug is going to reduce. And for that matter, you may not see the therapeutic effects of the drug. We don't. This thing that I am talking about, it's a serious issue. And most of us, you see, because you don't know, a lot of us don't appreciate these things. So we don't educate our patients well. Aside that, you will be there in the hospital. One of the things that I hope you saw in the slides is what we call the pharmaceutic phase. So for oral medications, they come in solids. All right, tablets, capsules, okay, caplets. So when you take it, they need to be dissolved first. It is not the solid form of the drug that is going to move in your body. The drug has to disintegrate, disintegrate. Then the active ingredients, the drug itself, is what the body picks up, absorbs it into systemic circulation, and then transports it to wherever the drug needs to be. So if you don't know things. You end up crashing drugs that you are not supposed to crash. I've seen several times how nurses, midwives, we crash nifedipine tablets. And I do believe you do it. Your patient is there, has had maybe a stroke, is unconscious or semi-conscious. The patient cannot swallow. Then the patient has been put on antihypertensives. Most of these antihypertensives are film-coated or enteric-coated. And when we say drugs are film-coated or enteric-coated, that means that you not crash them. You yourself, when you are crashing it, don't you see how hard it is? When drugs are enteric, it means that they are meant to be absorbed in the small intestine, not in the stomach. So you do it for patients with NG tube. Yes, but the NG tube is in the stomach. When the drug gets into the stomach, the gastric juices, the enzymes in the stomach destroys most of the drug. Have you realized that when we do that, it takes a very long time before the patient's blood pressure starts coming down? Yeah, I'm asking you. I'm asking all of us. Have you realized that? I think it was it Esau or one of them, the guys mentioned bioavailability. Bioavailability is the amount of drug that finally reaches systemic circulation after the drug has been what? Absorbed. So if you know that this drug bioavailability is 60%, meaning that by the time the drug gets through the stomach, the small intestine, passes through the liver, that is for a drug that is administered orally, 40% of the drug would have been lost, meaning that you have only 60% reaching systemic circulation. So, my brothers and sisters, this attitude of us, and I am hoping that we will stop. We have medications that you can administer to such patients. Labetalol is there, hydralazine is there. Okay. Sometimes, yes, their blood pressures may be such that it may not be indicated for you to administer the drug, administer maybe hydralazine or labetalol. But the thing is that you crashing the nifedipine, you are not, I mean, it is not benefiting the patient in any way. So there are a few things as nurses, we need to understand what we are doing and speak better for our patients. I've seen nurses try to crash Biku, Fesolate. How do you crash it? It's so hard. Most of the film-coated drugs, they are so hard. You leave it in water and it will take forever to even shed off the color. But you'll be there. And the sad part of all of this is that we don't have the medicine mortar and pestle to crash our medicines. What do we do? This one, I want one of you to tell me. How do you crash medicines on your ward? Jamila, please unmute.
Madam, please, we'll put it in a paper, in a plain paper. Then we use our, either the pen top, no? Then we'll be hitting it with it. Or if you have something that is hard, then use to hit it until it's crushed.
Yes. Yes, we have all done before. Please don't think that I have not done this before. We have done it before. Okay. I've seen so many of them. Asana, how do you do it on your word? Hello, Asana. You can
Can you hear me?
Yes, I can hear you.
Just like Jamila said, you just put it probably in a plain plastic something and then use maybe a used bottle or something. I guess add
Coke
some.
bottle.
Yes.
Coke bottle. Or some of on my one of the wards that I worked, it was the back then Especet. It came in a bottle, a hard bottle. So that was what we were using. And some of the paper that we use, some of them we just go for a report book. We tear the back. You see that thing? We tear the back of our report. Then we would just Felicia said you ask for spoon from relatives. Okay. So for medicines that you can crash, you need to do it the right way. Clean, and those even that have the mortar and pestle, please. Let me ask Dorothy. Dorothy, please, you can unmute. Wow, Benson, how can you be using the nurse's notes? No wonder we don't have nurse's notes to write. Eh? We can't find some of the papers. Anyway, let me ask Dorothy. Dorothy, you say you use the mortar and pestle. Can you let me see if I can get you to mute or to unmute Dorothy Tamaklu? Please, can you raise your hand so that I can let you unmute? I want to ask you a question because you are the only one who has said, "Hey, Sarah, Sarah, why you put it in what and use spanner?" I'm sure the spanner that we raise your hand, Dorothy, and I'll let you unmute. Okay. Let me see that comment again. Use spanner. Okay, Dorothy, please unmute.
Hello.
Dorothy, yes. My question to you is that how often do you clean your mortar and pestle?
Hey. Sister,
Hmm?
that one there. We clean it once in a while.
Once in a while. So you
Yes,
crash
yes.
para in it.
We
When you
crash the
finish, then you come and crash the Philippine in it. When you finish, then you come and crash what? Hey, hey, sister. So the person who is taking the nifedipine has traces of paracetamol, has traces of uh, buku, folic acid, what? Cefrozime, ebe,
tablet. Cipro.
aba, oh, sister. All right. I believe this one. If I don't have
We are all
to.
guilty.
As for the guilty, there we have been guilty for many years, and we are still being guilty. And the sad part is, we learn all about these things, and we learn them, but we don't go back and change. I'm praying that you will go and change. So, Dorothy, if you go to work tomorrow or Monday, as soon as you finish, okay, please wash it so that you put it there. And then tell your colleagues to also wash it after every medication. All right.
Okay.
Thank you
Right.
very much
Thank
for
you.
responding to my call. Okay.
You too.
So, so it's important that we study pharmacology. Okay. You have a plastic bag, Laurentia, that's especially made for crushing it. Wow. Can you please raise your hand so that we ask you to speak a little? Laurentia Atapitas, please raise your hand for me. Raise your hand. I want you to elaborate on your comments. Great. Okay. Please, you can unmute.
Madam,
Yes.
please.
So tell me about your special bag.
It's a plastic. It's a plastic bag. It is it's very small but solid. So we put the drug in it, then we crush it inside the
With
bag.
with what?
Just that we use something to hit it.
With what? What do you use? What is the something?
Maybe a hard more bottle or
Okay. Okay.
but we have a special, yeah.
Okay. And is it what for one medicine or
Yes, please. It's plenty. So when you want to crash, then you go for it.
just go and get one
Yes,
and then you
please.
put it
We have it
inside?
on the wall.
Yes,
Yes,
I think it's the Ziploc bag, the smaller ones that you are
yes,
using. Okay. That is not bad in a sense, but first of all, the medicines you are crashing, are they medicines you have to crash? That's the first question you need to ask. Then we look at how you are crashing. Okay, how you are crashing. So if it is a medicine you can crash, then no problem. You crash it for your patient. But if it is not a medicine you have to crash, like I'm saying, enteric coated drugs. So you see that they'll write it on the what do you call it? The cap, the box, the medicine box. All right. They'll write film coated. I just want to quickly show you a picture of it. And when you read about the drug, you clearly see that they've written do not crash. You see clearly they will write on the pack, do not crash, or in the under the what do you call it, medicine, the information leaflets. You look at a place, a heading, they've written drug administration or administration of the said drug, and they'll write there, do not crash. And once they've written do not crash, do not crash, please, I don't think they are the people who put it there. Do not crash. They are, excuse me to use the word, they don't have the sense. That's why they are saying do not crash. Okay. So I want to show you something. When you see that, I'm showing you. So when you see that they've written film coated or enteric coated, okay, please, I hope you can see. All right. Film coated or enteric coated. You are not meant, or you are not supposed to crash it. And the reason why you are not supposed to crash it is very simple. The drug is not supposed to be absorbed in the stomach. Okay. The drug is not supposed to be absorbed in the stomach. So you are not supposed to crash it. The drug is going to be dissolved and disintegrate in the small intestine. So please, when you see film coated, when you see enteric coated, please do not crash. There are always alternatives that the prescriber can give to the patient. All right. There are always alternatives that the prescriber can give to the patient. So discuss with the prescriber. My patient cannot swallow. My patient is unconscious, cannot swallow. Maybe the patient is vomiting profusely and so cannot keep anything down. Can we switch to oral, maybe intravenous? Can we switch to intramuscular medications, can we switch to any other form aside the oral? But we don't speak on the behalf of our patients. Some of us, we don't even know. Once it has been prescribed, hey, we need to find a way of getting it for the patient. All right. Yes, Mr. Mahama.
Madam, good evening.
Good evening.
My question is that we have a perception that all drugs that have depressed line in between them, dividing them into equal parts, are drugs that can be that can be crushed. Is it true?
Not all of them. For some of the drugs, they are just a design. You see, when you see the scored tablets, so scored tablets, we mean lines. Some of them, they are very hard to even break. Okay. So once it is scored, the idea is that it can be broken. If there is no scoring, there are no lines, you can't break them. But that's not the characteristic you look out for, whether you can crash or you cannot crash. Please, I'm not showing any slide now. I'm not showing any slide. Okay. If it can be crashed, you see it under the drug administration, crash. It can be crashed. But what I want you to understand is that when you see that it's film coated, it is enteric coated, you have to have that idea that you should not crash it. Please, you should not crash it. Mahama, I hope you get it. Gifty, please, you can unmute. I'm now coming to share my slides. So the one who was asking for the slides. Yes.
Please, my question is, administering drug through the wrong routes, will kinetic or the effect of the drug take place? Like in the case of the suppository, the drug that was supposed to be injected and was taken orally, will the effect still be felt?
No. You see, so you are supposed to insert this drug vaginally so that it produces the local effect in the vagina. It gets dissolved and absorbed in the vagina. If you swallow it, it is not made in a way that the stomach can break it down, and then it will be absorbed. No. And so when people take it, realize that no effect. Drugs are designed, other than that, there is no point in having the different dosage forms and the different routes. Every drug that has been designed, okay, in a particular way, that drug, so the drug that is supposed to be taken orally, has properties that have been put in so that it can be absorbed orally. There are drugs that have multiple routes that you can use, like Cytotec. Cytotec is an oral drug, but if you put it under your tongue, it can be dissolved and then also absorbed through the capillaries under your tongue. If you put it in the vagina, it can also dissolve in the vagina. All right. And then it will produce the effect that you are looking for. Okay. If you swallow it, yes, the drug initially was intended to be used for the treatment of peptic ulcer. And so once you swallow it, it would also work. Okay. But these other effects came out when people started using the drug. So yes, there are some drugs that even though you may use it in a different route, the same dosage form, but if you use it in a different route, the effects may be seen. But majority of drugs, if like you have let's say the pastries or suppository, and then you swallow it, that one, it doesn't normally work. But the drug that can be given IV, that can be given IM, okay. If you give it IV, it will work. If you give it IM, it will work. But if you give it orally, it will not work. That is why the dosage form is not in the oral form. Okay. Gifty, I hope I've answered your question. So let me see. Somebody is asking what will be so extended release, please. All of those ones, you are not supposed to crash them. So when we say extended release, the drug is supposed to be swallowed whole. Okay. You are supposed to swallow the drug whole, and it takes time to dissolve and the active ingredient picked up during a period. So if you crash it, you destroy most of the drug and you do not see the effects of the drug. You look at how these are patients who have high blood pressures and are unconscious and are on our wards, and we are giving them the oral medications. We've passed an NG tube, then we crash nifedipine, we crash the antihypertensives, the ones we are not supposed to crash, we give it to them. Look at the progression or how they recover. Just look at that. And you realize that what I am saying, so diazepam can be given. So if the drug can be given in that route, so let me just give you an example. Dexamethasone. I believe we know Dexa. Dexa, all along, the soluble, the injection one. All along, I knew you could give it IV, you could give it IM. Until I came across an American nurse who visited a hospital that I used to go and do some practice there. Okay. And she said, oh, so we had a child who had come in the hospital. We're trying to administer Dexa. We couldn't get the vein. We tried as much as we tried. We couldn't get the vein. The child was also so emaciated. We didn't also want to give IM. And so the nurse said, oh, this one, research has shown that you can give it orally. All right. We give it orally. So we just opened it and poured it into the child's mouth. And it worked. Okay, it worked. Suppository, the diazepam injection can also be given in the rectal, through the rectal route. It works. Ideally, it's supposed to be IV, IM, right? But through the rectal route, it also works because it also gets absorbed. All right. So, somebody is asking, a patient on NG tube on nifedipine, how do you administer without crashing? You can give the alternatives as Fatau has said. Isn't hydralazine short acting? Whether it is short acting, it is long acting, whatever it is, please, it is better. Even if it is short acting, I need to check which of the two is short acting. But whatever the cases, is better than you crashing nifedipine and giving it to the patient and the drug not having much effect on the blood pressure and the patient still being in the ward with a high blood pressure. The thing that's what I've realized, or what most of my patients and my students tell me when it comes to the use of labetalol or hydralazine, is the fact that you really need to monitor the patient. And they don't have the time to monitor the patients when they give them the medication. So they don't like giving it. That's what most of them tell us. Yes, workload and whatever. So please, let's not, how do I put it? Let's not, let's think about the patient, okay? Let's think about the patient. Let's think about the patient that the drug that you are given, okay, it has to work for the patient. After all, they are paying for it, whether it is insurance or not, or they are paying out of pocket, whatever it is, they are paying for it, and they are supposed to get the best out of the pharmacological treatment. So if you give it, all right, and the patient is not benefiting from it, then you are not helping the patient in any way. Okay. All right. Ishmael, do you have a question?
Madam, I want to know about the diazepam injection. You said it can be given rectally because it is in a
Oh, okay.
liquid form. How do you give it?
Okay,
Because it's in
so
a liquid form. How do we give it rectally?
all right. So this is how I've seen it being used. One of them you use we use a 2cc in the hospital where I worked. That is how we often do it. We use the 2cc. We draw um diazepam, and then we insert the 2cc in the anus and we push it, hold the child's bottles for the it absorbs quickly because the rectum is very hot and blood vessels are there, and so it gets easily absorbed. We have big blood vessels that it gets easily absorbed. I've also seen ones where they soaked it in cotton and inserted it into the anus, but that was just once. It's not something I've seen it often that is being done. All right. And one of you even made a comment that um somebody wrote something in the chat that is how they do it. All right. The cotton one, but I really don't know. I've just seen it being done, but the one we use the syringe, with the yes, the syringe. I personally have been doing that, and I see it done mainly in pediatric units, not in adults, in pediatric units, and mainly we use it when they come in with convulsions. I don't know,
Thank
can
you.
the person who made the comment about it using the yes, somebody says they impregnate it in cotton. Okay, so I'm sure that can also be done, but personally I have not tried, though I've seen it being done. Okay, so yes. So Latif, just another question so that we can move on. Okay.
Good afternoon, madam.
Good afternoon.
Yeah, please, I want to find out, since it's IV medication and you said you can give it through the rectal route, can the dose be changed or you can give the same dose as compared to the one you're supposed to give through the IV?
So the dose for the child, okay, if you are giving 5, I think it's 5, it depends, 5 milligram, 10 milligram. If you are giving it's the same thing. You just withdraw it and then you put it in there. It's a very highly vascularized area, just like the sublingual route. Okay, very highly vascularized. So absorption is quite fast. And if you happen to be in a pediatric ward, actually the first time I saw it being done, I was like, how can you do that? The drug will just come out. And the nurses who were working there said, oh, no. And this time I was a student. At that time I'd not even finished nursing undergraduate. So the lady said, oh, you too, this one, it will be absorbed quickly. You don't need to change the dose. It's the same, the same thing. It's very fast. The moment we administered it, and then I mean, it's like, I don't want to use the word magic, but the convulsion ceased immediately. Mm. Putting what in the IV fluid. Are we still talking about diazepam? I don't know. Let me look at the name. Deborah. Okay, I hardly see diazepam being put in IV fluids to be administered over a period. I've not really seen that, but the rectal route many times. Okay. As for the questions, okay. Daniel, you can unmute.
Yeah, thank you very much, madam. Please, realistically, I'm finding it difficult to understand the crashing because I stand to be corrected, but most of the time, the extended releases, the long acting, most of them are quoted. So, example, in case you want to give maybe an AC inhibitor like Snowfall, and it is quoted, so you can't crash it. What will be the alternative? Because most alternates, the IVs are short acting. So in case someone is on NDT,
the trick
probably
is that if the patient comes and is unconscious and they have very high blood pressure, you need to first of all categorize it. Is it an emergency, a hypertensive emergency, hypertensive urgency? In that instance, you don't need an oral drug. Let me give you a scenario. If a patient comes in with an asthmatic attack, is that the time you are going to give salbutamol tablets? Daniel?
No, madam. Please, in a scenario of a patient, a CDA patient who is not an emergency case, but still has to be managed.
I'm not talking about emergencies. Listen, if somebody comes in and the patient is not able to swallow, the patient comes in with a CVA and the blood pressure is high, you need to bring it down to the normal. And the oral drugs will not help you to do that as quickly as possible. You need to use the IV to bring it down to the normal. Then you can, and by that time, trust you me, if you're able to do it and do it well, the patient recovers. The patient recovers. So that the patient can now start taking oral fluids. But if you go ahead and crash them, okay, you destroy the drug. There is something that we are going to talk about in a couple of minutes, something we call bioavailability. It's one of the parameters when we are discussing absorption. There are two parameters, two things we talk about there: bioavailability, first pass effect. Okay, so if the patient comes in and the patient cannot swallow, the patient cannot swallow, please, you have to give the patient the IV for the period which the patient is unconscious. And there is a protocol for it. So you follow the protocol, get the person's blood pressure to come down, and hopefully when the blood pressure comes down, the patient will be able to recover in such a way that they are in a state where they can swallow, or you can administer an oral medication so that you administer the oral medication. You keep on crashing it and it is not working, and you are crashing, and you wonder why the patient has been on your ward 5 days, 1 week, no improvement, blood pressure is still high. Please, this is the point where you need to think about science. pharmacokinetics, where what is happening to the drug? Is the drug being absorbed in their right quantities? Is it reaching systemic circulation in their right quantities? Has it reached the critical concentration yet? There's what we call bioavailability. I think I need to just move to that place. Let me see if it's part of this slide. Okay. That will be the B. So let me open that one. Okay. And then I'll show you what bioavailability is, and maybe you'll be able to appreciate what I'm saying well. Okay, so let me share that one. John, please, just a moment. Let me explain a little bit here so that all of us. All right. So, bioavailability. Please, can you see my screen? All right. I do hope you can all see now. So, there is this parameter in oral absorption, not just oral absorption, but in pharmacokinetics and the absorption that we talk about. Okay. Bioavailability. So, two words. Bio relating to the human body. Availability, as for availability is English. What word can I use to describe availability? Yes, it is there, it's available, right? Okay. So when we say bioavailability, we are talking about the amount of drug or the fraction of the administered dose that gets absorbed into systemic circulation after the drug has been administered. So when you administer a drug through whichever route, whether it's IV, IM, sublingual, the oral route, the buccal route, whichever route, okay, whichever route that you use, there is an amount of the drug that finally reaches systemic circulation and gets transported throughout the body. The amounts that you administer at the beginning is not the same amount. If you take the IV route, the drug is administered straight into systemic circulation. So in actual fact, for the IV route, you are supposed to get 100% bioavailability. But even that, it is not so. It is not 100%. Because as we will get to know, the plasma also contains drug metabolizing enzymes. So as you administer the drug, some of the drug will be metabolized in the plasma, in the blood. Okay. Now, if you administer a drug orally, so the person swallows the drug will pass through the esophagus, get into the stomach, gets into the small intestine before it is absorbed through the portal circulation. That is because anything that goes through the mouth, okay, it needs to go through the liver for the liver to make sure that what is getting to the rest of the body is okay, is good. So it gets absorbed into the liver. Here, there's a process that goes on, what we call pre-systemic metabolism or first pass effect. Once the drug also gets into the stomach, you know the content of the stomach already. We have enzymes in the stomach. We have gastric juices in the stomach. That we have hydrochloric acid in the stomach wall itself. Okay, so there are things that are in the stomach, and sometimes even the food that is in the stomach prevents some of the drug from being absorbed. So what you administer, okay, you would you realize that all of these factors will play a role, and by the time it reaches systemic circulation, you will not have anything. You have most of the drug destroyed. Just a moment, please. Hello. Please forgive me. So I needed to one of my neighbors' child just uh, had a convulsion. They've taken her to the hospital and they were calling me. So please forgive me. All right, let's go on. So we're talking about um bioavailability. So what I was saying is that the amounts of drug that you administer is not the same amount that reaches systemic circulation. All right. And for the bioavailability of the drugs, the routes, okay, we have ones that bioavailability is high, meaning that if you administer the drug, majority of the drug would be absorbed into systemic circulation. Then we have routes that the bioavailability is also very low. It means that when you administer the drug, you have just small amounts that would be absorbed into systemic circulation. So imagine if I have a drug, amoxicillin, the bioavailability, I think, is 60%. So I'm asking all of us, if I have 625 milligrams that I am administering a typical adult, how much of it would be absorbed into systemic circulation? This is a question that I need all of us to try and solve. I'm saying that the bioavailability is about 60%. I'm administering 625 milligram tablets. Okay. How much of the drug would be absorbed? Are there mathematicians in the house? Constance, please unmute.
Madam, please, 37.5%.
60% of 600 and let's do the calculation well. Say it again.
Madam, please, I had 37.5%.
37.5. Okay, let's see. All right. Let's hear another person. Adam. John, your hand had been up for a while. John, are you done? You can unmute, please, John. Or let's go to Adam.
Hello, madam.
Yes.
Good afternoon, please.
Good afternoon.
Please, I had 375 milligram. And in males, that will be the 37.5.
Please, I didn't give you the volume. So I'm wondering why you are giving me an answer in volume. I only
Okay,
give
I mean
you
375 milligram.
Yes. All right.
Will be the bioavailability.
Yes, that is the amount that is going to be absorbed. I want us to get it clearly. And please, let me say this right from here. A number without a unit means nothing. I am saying it again because I've seen some of us, we have just written the 375. Sorry, without a unit. A number without a unit, it means nothing. Because 75 milligram is not the same as 75 cedis. Please, I hope you understand me. All of us, do we get this? 75 milligram is not the same as 75 cedis. And definitely 75 Ghana cedis is not the same as $75. 75 cedis. They'll tell me that the amounts are not the same. So please, let's get these things clear. When it comes to doses, we need to be as accurate as possible. Second thing I'll say is that numbers and units are not written together. The SI units guidelines tell us that a number should not be written, okay, should not be written with the unit attached to it. So you cannot, please, we would solve it together, please. Okay. You cannot write, let me annotate here and then show you. So you can't write like this, 75 milligrams. This is G. This is not the same as 75 with the space. Please, let's know that. Okay. Let's note these things. All right. Let me show you how some of us were not paying attention, so we seem lost. All right. But let me show you how we arrived at the answer. I'm loading a whiteboard. So you should see a whiteboard. All right. And I told you that bioavailability is the amount of drug or the fraction or the proportion or the quantity of the drug that reaches systemic circulation. So I said that we have 625 milligrams of amoxicillin that we are administering. The bioavailability is 60. Please, those who are writing, stop. Don't touch my screen. You can't write on it, please. Stop writing. Don't stop touching your screen. Okay. All right. $625 milligrams is what will reach systemic circulation. So if I want to know the bioavailability, all right, all right, it will be 60 over 100, 60% percentage over 100 times the 625 milligrams. And when you do use your calculator, or if you want to do the manual one, okay, these zeros will cancel each other out. 5 will go in here, 2, 5 will go in here, 1, 2, and I think, what's 3? I think so. 1, 2, and 3. Then 2 into go in here, 3. And I think if you multiply it, you should be able to get it. If my calculation, for, please, stop touching the screen, okay? And please stop touching my screen, all right? Okay. Yours is all white because people are moving the screen. I don't know how to stop people from moving the screen. I don't know how to do that. Okay. All right. But somebody even did, you can only see half because probably your screen, people are moving it. So let me use what Edward has done. Go to the chat. Edward has solved it there. Okay. And it's the same thing. The only thing I'll say is that Edward, don't write numbers and units together. Okay, it is not scientific. There should be a space between the number and then the unit. Great. So that is bioavailability. John, your hand has been up for a while. Okay, your hand has been up for a while. You can unmute.
Thank you, Mom. Please,
John, please hold on. While John is speaking, I am going to solve it and put it in the chat. All right, John, please go ahead.
Okay, thank you, Mom. Please, I want to find out, there are instances you would give a client an oral medication, especially the pediatric unit, and 1 to 2 minutes later, the child will vomit it out or vomit out. So my question is, will it have effect on the bioavailability of that drug? Would there be a need for us to give another one because the child vomited? And another contribution I want to make regarding the rectal diazepam is my place like this, if we are not getting the 2 cc and there is 5 or 10, what we do is we use a cannula. We remove the needle out and fix the cannula with the syringe and push it inside.
Wow. I learned something every day. Thank you very much. That is not a bad technique at all, I think. But please, if I may ask, which size of the cannula do you use? I don't suppose to use the yellow.
Actually, we use the yellow color.
The yellow, that's small. That's quite small. But anyway, I think it's something that we can all learn from. If you don't have the 2 cc, you can do that. You can use the cannula to do it. As for improvisation, nursing in Ghana, we are number 1. We always find a way of doing things. But to answer your question, first of all, I'll use that to also answer one question that has come up. Please, bioavailability varies for every drug. It ranges from 0 to 1 or 0 to 100%. So every drug, the bioavailability is going to be different. There are some drugs that the bioavailability is 90%, meaning that if you have a dose of, say, 500 milligram and you have to administer the drug, you need to think, okay, so this drug I'm administering, the bioavailability is 90%. Okay, it means that what will finally reach systemic circulation is 90% of the 500 milligram. You can do that calculation right now for yourselves. So 90%. So 90%, that means that 450 milligrams, okay, is what is going to be absorbed. So first of all, every drug has its own bioavailability, and you can easily find this information. You look under the pharmacokinetic profile of the drug, and it is there. So once we are through with pharmacokinetics, I'll show you how the pharmacokinetic profile is put when you are reading about the drug information. You find the bioavailability. You find, first of all, you find the various routes that you can administer the drug. If there is a need for a change in the quantity of the drug for the different routes, it will be said. It will be mentioned. If it is IM, this is how much you can give. If it is IV, this is how much you can give. If it is oral, this is how much you can give. Then the bioavailability will be stated. The what we call protein binding, we will talk about that, would also be stated. The routes through which the drug will be metabolized, organs that the drug it will be stated, excretion, it will be stated, half-life. So all of that under the pharmacokinetic profile. All right. Now, Adongo, please, I'm not sure if I've been able to answer your first question clearly. Can you please unmute and ask the question again? I think I didn't get the question, so I've not answered it well. Please, you can unmute.
Yeah, ma'am. It was a different person that asked about how the drug, if drug vomits the drug a few minutes after.
Yes. So the general rule, please, you can hold on. The general rule is that if you administer a drug and the person vomits within the first 15 minutes, okay, it is assumed that the drug will not be absorbed, so you administer the same dose again. Generally, when you administer a drug orally, the disintegration and the dissolution will happen within about 30 minutes, unless it is a syrup. If it is a syrup or a suspension, it's already in the liquid form. So for that one, if the child vomits within the first 15 minutes, whether you see traces of it or not, you administer the dose again. If it is after 30 minutes, you need to check. Do you see it? If you don't see traces of it, you can administer half of it. Okay. But if within 2 minutes, whether it's a child, whether it's an adult, and the person vomits, and for some of them, you can clearly see traces of the drug in the vomitus, administer the drug again. I hope I've been able to answer. Okay. All right. Now, Dongo, please, you can unmute and ask your question. Yes.
Yeah, please, my question is, if a drug has a low bioavailability, does that affect the half-life of the drug?
Right. Thank you very much. So if a drug has a low bioavailability, it affects one, how much of the drug is absorbed, what reaches the critical concentration. This tells us that you need to administer the drug quite frequently to reach the right concentrations for you to see the therapeutic effects of the drug. Okay. Now, does it affect the half-life of the drug? Yes, it would affect the half-life of the drug. The time itself will not necessarily be affected. Let me be clear. The half-life will not directly be affected, but the amount that would be eliminated is going to be affected. Let me say it again. Half-life is the time that it takes for the concentration of the drug to be halved, or it is the time that it takes for the concentration of the drug to be reduced by half. So when we say the half-life is time, it ranges from minutes to days. So if the half-life of a drug is, say, 3 hours, it means that every 3 hours, half of the concentration of the drug will be eliminated. So if the amount that reaches systemic circulation is low, it means that the amount that is going to be eliminated would also be low. Please, Adam, do you understand what I'm saying? Or the rest of us?
Yes, please.
So if I have a drug, it has it's 100 milligrams, 30% bioavailability. It means that only 30 milligrams of that drug will reach systemic circulation. If the half-life of the drug is 3 hours, it's still going to be 3 hours. But the amount that is going to be eliminated is going to be what? Half of the 30 milligram that was absorbed. Please, I hope you get it.
Okay. Yes,
all right.
please.
Good.
Yes, please.
The same drug that is administered both anally or via IV. Yes, bioavailability. I showed you a slide. I'm sure. Let me show it again. I showed you a slide showing you the ranges, the bioavailability range for the various routes. So if you pick a particular drug that may be administered orally, you may have a range between 5 to less than 100%. Please, I hope you get it. All right, somebody's is giving feedback. Okay, forgotten the person. All right. Philippine, please, you can ask your question, then I'll answer a question that was asked about half-life and bioavailability, first pass effect, and then yes. So Philippine, please, you can unmute. Oh, okay. Adongo. Okay, so there's Adongo and then Arongo. Okay. So Adongo, please, you can unmute.
Please, yes. What I want to find out, as we talk about the bioavailability being the amount of the drug that is being absorbed into systemic circulation, does any factors the patient or the food that they eat, the patient have taken, or any or environmental factors that does they affect the bioavailability of a drug at a particular given time or particular situation?
Oh, yes, there are factors that affect bioavailability. One of them is the presence of food. So, you know, there are some drugs that you have to take with food to enhance its absorption. Okay. And there are drugs that you have to take without food to enhance absorption. For most drugs, the presence of food sort of delays absorption. Okay, so if there is food, or you are on certain drugs and you are asked not to take certain foods like the fluoroquinolone, so you are on Cipro and you are asked not to take dairy products, and go ahead and you take dairy products, the bioavailability is going to be affected because most of the drug will not be absorbed. So even if it has a bioavailability of, say, 70%, okay, that has been factored into you not taking it with the dairy products. So if you go and take it with the dairy products, it means that you are going to further reduce the amount that gets absorbed. So there are factors that would affect bioavailability. And if you go on to read the slides, I shared a couple of them with you. Okay, please let me talk about the parameters that we talk about when it comes to drug absorption. Then we'll talk about half-life, because we are going to talk about half-life. Now for first pass effects, let me bring it in again so that we all understand. It's the same as pre-systemic absorption. Metabolism. Okay, when we say the first pass effect is the same as pre-systemic metabolism. And this will happen to drugs that is administered enterally, the enteral route. So when it comes to drug absorption, one of the factors that affects it is the route of administration. Okay, is the route of administration. For the route of administration, when it comes to absorption, we classify or we categorize them into two main routes. We have the enteral routes, which is the oral and the rectal. Then we have the parenteral routes. So any route that absorption happens outside the GIT, any route that the absorption will happen outside, it means that it will not go through the gastrointestinal tract. Those are the parenteral routes. Please, I hope you get that. So when a drug goes through the parenteral route, all right, the drug is either going to be absorbed in the stomach or the small intestine. Majority of drug absorption happens in the small intestine. All right. When that happens, the drug has to go through the liver. Okay. The drug goes through the liver before it gets into the systemic circulation. And by the drug going through the pre-systemic metabolism, the drug is then the outcomes. Some of the drug may be absorbed, some will not be changed at all, some will be destroyed by drug metabolizing enzymes. And so all of these affect the amount that finally reaches systemic circulation. So when the drug is in the small intestine, the portal vein picks up the drug and delivers it to the liver. It goes through the liver, and then the hepatic vein takes it to the heart and then to the rest of the body. So when this happens, and this will happen for drugs that will go through the oral route, okay, it will also happen for drugs that would go through the rectal route. But for the rectal route, if the drug is put in the lower rectum, so among just the end, the tip of the rectum, this one, the drug will not go through, it will bypass the liver. But if it goes into the upper rectum, this drug is likely to go through the first pass effect. So any drug that is injected, so it is ingested, it is swallowed, any drug that is put in the upper rectum, these ones would go through the first pass effect. And this is the situation where the drug is absorbed through the portal system into the liver, and the drug is metabolized, and it is then absorbed into systemic circulation. And this one will happen even before the drug gets to wherever it is going to do its work. Please, that is why it is called pre-systemic or first pass effect. Now, this means that if a drug has an extensive first pass effect or is extensively metabolized pre-systemically, it would also affect the amount of drug that reaches systemic circulation. Please, I hope you understand this part. And this will happen before the drug is absorbed and distributed to the rest of the body. Mahama, please, you can unmute.
Madam, what I want to know is, does that mean that a drug can reach the first pass effect before bioavailability can be achieved?
Please, so let me clarify this. The drug does not reach first pass effects. The drug, when it is administered orally, would go through this, would be pre-systemically metabolized before it reaches systemic circulation. Now, bioavailability is the amount of the drug that gets absorbed. Please, I hope this is clear. Let me, the last time somebody called that I should explain, I used a scenario, it helped the person understand. Okay. So I am in Kumasi. I am going to Accra. There are several ways I can get to Accra from Kumasi. I can take a flight. Within a short time, maximum 30 minutes, I'll be in Accra. I can go with a bus. Maybe around 4 hours, 4.5 hours, I'll be in Accra. I can drive myself to Accra. On a good day, it may take me about 3.5 hours to get to Accra. A good day with a good car, I should be in Accra in about 3.5 hours. I can decide to walk. That may take me several days to get to Accra. I can decide that, okay, I will take a motorbike or a bicycle. That would also take me a couple of days to reach there. All right. So my end is that I need to travel to Accra. Now, before I can use any of these routes, I may have to buy a ticket. Even if I am driving myself, I will have to buy fuel to put in the car. Unless I am walking, even the walking, I would need money to buy water on the way, buy food on the way. So whichever way, there's money involved. Please, I hope you are following. Now, if I decide to go with the bus, it means that I have to find myself to the bus station, pay for a ticket, and it will take me to Accra. If I don't buy a ticket, I can't go with a bus. Please, I hope you are following. So, I want to get to Accra. I want to use the bus. If I don't go to the bus terminal, the VIP station, buy my ticket, get into a bus, I will not be able to get there. So me going to get the ticket, sitting in the bus, traveling to Accra, which is my destination, you can liken it to the first pass effect. Okay. Now, if I have plenty things and the bus tells me that, oh, they can only take 2 of my bags and I'm not able to pay for the rest of the bags, it means that it's only 2 bags that will get there. Or I get there, the bus is full. So only one of my bags can go. It's only 1 bag that will get to Accra. Please, I don't know if it is this scenario is helping any one of us. So when the drug is administered orally or through the upper rectum, the drug will go through the liver before it will reach systemic circulation. So by the drug going through the liver, because you see, anything that gets into the stomach through the small intestine goes through the liver. It will go through the liver. For the liver to say that, oh, okay, this is good for the body, this is not good, get rid of it. So it goes through the liver before it reaches systemic circulation, and the drug gets distributed to the target. So by me going to get a ticket, sitting in the bus, okay, I am trying to get myself from Kumasi to Accra. But if I decide that I want to go to Accra, but I'm going with the bus, and still I will not go and pay for the bus, how would you reach Accra? If I pay and I don't pay enough to cover my luggage, how would my things reach Accra? Maybe my body will reach there, but my things will still be in Kumasi. I don't know if this is helping. So once you take the drug and it goes into the stomach, it gets into the small intestine where absorption takes place, the drug will go through the liver. And this will happen even before the drug gets distributed. Drug distribution will happen after the drug has reached systemic circulation. Please, distribution will happen after the drug has been absorbed into systemic circulation. So when the drug reaches systemic circulation, then it gets distributed. So once I sit in the bus and I am on my way to Accra, I'm being transported from Kumasi to Accra because that is my destination. If I don't get in the bus, I will not be taken to Accra. If I don't get myself in a car and drive myself there, I will not reach my destination. So the drug is supposed to get into, let's say, the brain. If the drug does not reach systemic circulation under the right concentration, under the right circumstances, the drug will not be absorbed into, will not be distributed anywhere. So the first thing is that when you administer a drug, the drug has to be absorbed. How much of it is being absorbed depends on the route you are using. It also depends on factors such as the first pass effect, bioavailability. How fast the absorption will happen would also depend on the route you are using. Because if you want a fast route, that is not when you are going to give the drug orally and say that, oh, the patient is afraid of injection, or the patient is, it does not, meanwhile, the patient is dying. A patient comes in with an asthmatic attack, and you want to administer salbutamol tablets. When will the tablets get dissolved, disintegrated, for the body to absorb it, for the drug to go through the first pass effect, for the drug to be, how? Meanwhile, if you have the nebules, you can easily nebulize this patient, and the patient will get well quicker. Okay, so pharmacokinetics is very important in our everyday work as nurses. The choice of route is one of the things that we need to consider if we want to improve on the extent and the rate at which the drug is going to be absorbed. Okay. Ebenezer, please, you can unmute.
Okay. Thank you, Mom. Per your explanation, I think with the previous slide you gave us about the difference in the bioavailability, we can see the route that is of the GIT is of less bioavailability due to the greater first pass metabolism caused by the liver cells that metabolize most of the drugs before it enters into the systemic circulation. But then other routes too also have the bioavailability also not present. I think there is also the first pass metabolism that is occurring at the.
No. Let me stop you right there. Please, let me stop you right there. Let me hold on. Ebenezer, please listen to me. Listen to me. First pass metabolism happens in the liver.
Only.
Yes. Now, metabolism, extrahepatic metabolism, you don't classify it as first pass metabolism.
Okay, thank you,
Now,
Mom.
there are other factors. If you administer a drug into a muscle, depending on the muscle type, the flow of blood in that particular muscle all affects the bioavailability, the amount that finally reaches systemic circulation. Even the type of needle. You see, if you are administering a drug into the shoulder, right, as against the gluteus, okay, the muscles there are different. If you choose a needle that would not take the medicine into the right muscle, it is going to affect the bioavailability. Let's say the drug is supposed to be absorbed in the muscle, and you administer the drug into the subcutaneous. It is going to affect the amount of drug that is finally absorbed by the capillaries in the muscle. Okay, so it is not just the first pass effect and that affects